Now I'd like to invite Dr. Chavan sir and Dr. Kalantri sir to moderate this session. I'd like to request Dr. Abhay Kasliwal sir to come up on the stage for moderating this session. Now I'd like to invite Dr. Ajay Vare sir to present on radiological science in chest radiograph.
Good morning, everyone. By the time he sets in everything, let me take this opportunity to thank the organizers for giving me this wonderful opportunity to discuss basic chest radiographs and the various signs with you all. I would like to also congratulate our lady team yesterday. The energy was awesome. You know, we all enjoyed, and I request you all to give a big round of applause for all of them. The boys were good, but not that good. So yesterday, kal ki sham, girls ke naam. So yeah, that's true. Someone has to speak it out also, so that's why. So the basic objective of today's talk is we need to recognize some radiological signs to arrive at a diagnosis. To arrive at a diagnosis, we need to understand the mechanism of what is happening, the basic pathophysiology, how these signs come up, and then it makes us or helps us to arrive to a reasonable practical diagnosis. So why do we need these signs? Basically, as we all know, we have been born and brought up, and all these signs were taught to us in almost the first or second year of our residency. And it is especially important as far as the exams, the MD exams are also concerned. We keep on discussing this day in and day out, but I don't know what happens in the exam. So everyone tries to, give answers which are not expected. So I think we have few residents here, so we'll see. So these signs help us to locate the lesion in the chest, whether it is intrathoracic, extrathoracic, whether it is intraparenchymal, extraparenchymal, and if at all it is a mediastinal lesion, whether it is anterior mediastinal, posterior, superior, inferior, and so on. Coming to the foremost sign, very important sign, I think I'll skip the theoretical part, we'll just directly talk on the images. So as you can see here, there are a lot of opacities in bilateral lung fields involving almost all the entire right lung and sparing the upper lobe on the left side. You can see this tubular opacities, tubular lucencies in the homogeneous opacities, giving a branching sign as we see a tree with shed of leaves, a dried off tree, something like that. So these tubular bronchi are seen in the opacity. This usually happens because the air spaces around the bronchi are filled with fluid, interstitial edema, and all the alveolar spaces which are usually patent and filled with air are replaced with fluid. So this is the basic pathophysiology or the mechanism how the air bronchogram sign is seen. And as the age of the consolidation progresses, these bronchi are filled with the inspissated secretions with drop-in inside the bronchi, and later on the homogeneous opacity is seen. These tubular lucencies are lost over a period of time. It still remains the consolidation, the diagnosis remains the same, but the stage has changed. So if at all needed, we might be in a better position to talk about it on a HRCT. As you can see, we have a CT image also, and I'll show you a next example. You can see here, these lucencies have reduced, and if you scan, if the patient is not responding to treatment, this may increase, or increase in the sense the lucency will be lost and it will be completely homogeneous. Second important sign is air crescent sign. This is usually seen within a cavitary process or a cystic or a hydrated cyst which communicates with the bronchi, and there is a thin crescent of air in the opacity. As you can very well see here, there is a thin crescent. This is the case of hydrated cyst with a thin crescent of sign. This is a fungus ball, a thick walled cavity with a crescent sign here. So this crescent sign usually announces recovery. By that I mean whenever a cavitary process starts communicating with the bronchial tree, most of the secretions are cuffed out. So the patient starts coughing out, and then this was the point when it says the recovery has started. But it is not true in all the cases, because in cases of vaginous granulomatosis and other conditions, this may not be a favorable sign. So whenever you see a cavitatory process, it is always better to have change in position with the radiographs or with the CT scan. As you can see here, multiple rounded opacities. These were fungal balls and the cavities here. They are multiple in number, immunocompromised patient, and this patient succumbed after say 8 to 10 days because he had cerebral lesions also. I see a lot of residents here. Can you help me with the diagnosis here? What is happening here? Anyways, this is not an exam, so you can at least guess. So can you see something here? Yeah, exactly. So it's a continuous diaphragm sign. Usually what happens, we don't see this interface. We don't see this air interface because the heart is sitting on the diaphragm and there is no difference in the opacity. Hence, the continuous diaphragm sign is not seen. So whenever there is air interposed between the heart and the diaphragm, you start seeing the diaphragm throughout its continuity. Hence, it is called as a continuous diaphragm sign, and it is diagnostic of mediastinum. Sorry, it is a diagnosis of pneumomediastinum. Yeah. Another case scenario wherein you see a continuous diaphragm sign is not always for pneumomediastinum, it is always with air in the peritoneal space. Okay, whenever you see a lot of air in the peritoneal cavity, you can see the diaphragm throughout its continuity. The air is delineating the diaphragm from its inferior surface here. So this is also a case scenario where you can see the continuous diaphragm sign, besides pneumomediastinum. Deep sulcus sign, these signs are usually important in ICU settings, neonatal chest radiographs, which all of us know that it is challenging and it is not easy to report neonatal chest radiographs because they are not done in the ideal settings. ICU radiographs, the patient is critical, not ideal position, he is either supine or recumbent, lot of tubes and lines inside, the technician is struggling, we are struggling for reporting. So the basic intention of this is to include the CP angles in the FOV. We request our techs to at least include the entire chest, at least the CP angles in an ICU chest radiograph, because what happens, besides air under the diaphragm, this small amount of air in a supine position is extremely helpful. These are gross cases of pneumothorax, but 30% of pneumothorax are missed in supine chest radiographs in ICU settings. That's why this deep sulcus sign helps us to pick up small amounts of pneumothorax, which are, when the patient is lying down supine, the air collects basally and anteriorly. So the anterior deep sulcus is usually opacified with air. So that is very important for us to pick up, and that changes the entire treatment protocol. Ring around the artery sign, this is not a very important sign, not very commonly done also. This is just a, this is usually associated with air around the artery, the right main pulmonary artery, usually seen on lateral chest radiographs and CT of course, but this is usually seen in cases with polytrauma, road traffic accident cases with pneumomediastinum, pneumoperitoneum and things like that. And additionally you can see air surrounding the artery here. You can see this lucency around the right pulmonary artery. You can see some subcutaneous emphysema and air in the mediastinum also. Spinnaker sign, this is also called as thymic tail sign or angel wing sign. This is basically seen in pneumothorax, and this is usually the thymus is delineated with air. Usually we don't see thymus, and it, as we all know, as the age progresses, it regresses in size. But this is especially important in pediatric chest radiographs, wherever you see a thymus very, very clearly, usually the thymus is blurred with the cardiac silhouette. So this thymus, when it becomes very evident, you can see the thymus very, very easily. That is an indirect sign that there is some amount of pneumothorax there, and it is outlining the thymus very, very clearly. You can see the thymus is so clearly visualized here as it is surrounded by the air, and it gives, it appears like a spinnaker on the boat. Hence it is called as a thymic tail sign or a angel wing sign or a spinnaker sign. Finger in glove sign, this is also a very common sign and useful sign, usually seen in mucus impaction of the bronchi. It usually starts in the perihilar area, goes peripherally and tapers down like a branch of the tree. And this peripheral part of the lung is aerated by pores of Kohn and canal of Lambert. So whenever the bronchi are obstructed, distal aeration or distal circulation of the air is done through the pores of Kohn and canal of Lambert's. Very commonly asked in the exams also. Very famous sign, very important sign given us to us by Ross Golden in 1925. It usually, whenever you start seeing a golden S sign, you should suspect these conditions like central neoplasms, CA bronchus, mediastinal nodes, metastasis, or something wrong in the hilar area, central part of the chest, which obstruct the flow towards the peripheral part. This is how a golden S sign or a reverse S sign looks like. It is an S here. The inferior margin of the S is convex medially and concave laterally. Because the mass is sitting here, hence it is bulging out, and there is collapse consolidation distally, hence it is collapsed here. So this is a typical golden S or a reverse S sign of golden. Double density S sign, it is a very, very simple thing, usually seen on a posterior anterior chest radiograph, wherein the left atrium is enlarged and it appears as a double density on the shadow of the heart, and it is usually seen by splaying of the main bronchi, splaying of the carina. Okay, so there is widening of the carinal angle, and if you do a barium swallow, you can see the esophagus is indented and displaced posteriorly. So this is part of the conventional radiology, but it is important from the exam point of view. Donut sign, it is also seen in cases of mediastinal lymphadenopathy when there is lot of adenomegaly, very easily seen on CT. But since we have a chest radiograph here, these are 3 different cases. This one is normal, as you can see the vessels and the lucency of the bronchi here. This is a case of adenopathy wherein there is a homogeneous opacity which is surrounding the patent bronchi, giving a donut sign. And this is a case of pulmonary hypertension wherein the vessel is surrounding the patent bronchi. Silhouette sign, a very, very famous sign, a very, very commonly used sign. It was defined by Benjamin Filson in 1950. We all have read Filson during our residency, and these are extremely important signs. What happens is, whenever an opacity of the same density, they come opposite to each other, the interface is lost. So this sign helps us to locate the lesion inside the lung or the thorax, whether it is anterior to the heart, posterior to the heart, it is in the anterior mediastinum or the posterior mediastinum. So the basic importance of a silhouette sign is to locate the lesion within the thorax. I'll show a few examples of this. See, for example, this is a straightforward case, but if there is a opacity sitting here, opacifying or silhouetting the aortic knuckle, that means it is a posterior mediastinal lesion. You can say on the chest AP or a PA chest radiograph itself, there is no need of a CT, no need of a lateral chest radiograph. But there are case scenarios when we need to confirm it. So this was a case of hydrated cyst in the anterior mediastinum or the middle mediastinum, and you can see it is silhouetting the lateral or the right margin of the heart. Cervicothoracic sign, this is again a very, very important sign. As we all know, the level of the clavicles is, the anterior mediastinum lies below the level of the clavicles. The middle and the posterior mediastinum lies above the level of the clavicles. So as we go posteriorly, the level of the mediastinum goes up. You can see here. So this is the level of the clavicle. The anterior mediastinum is limited by the clavicle. Middle and posterior mediastinum extend above the level of the clavicle. This is above the level of the clavicle. So whenever you see an opacity, and the upper margin of the opacity is limited by the clavicles, so that usually says, not always, usually says that the lesion is located into the anterior mediastinum. Okay, so you can see here a lot of right paratracheal nodes and anterior mediastinal nodes. So on this sign, you can see the upper margin of the opacity is not crossing the level of the clavicles. Hence, we can confidently say that this is an anterior mediastinal lesion, and we need to confirm it, of course, on higher modalities like CT. This opacity is crossing the clavicles and going above the level of the clavicles. It's a very straightforward and simple thing, but it creates confusion at times. So when we did an MR and confirmed it, it was a paraganglioma in the posterior mediastinum. because it was extending above the level of the clavicles. We could say either it is a middle or a posterior mediastinal lesion, and we need confirmation. So we confirmed it on MR. 1-2-3 sign, also called as Garland sign. This is only used to differentiate between sarcoid and lymphoma. Adenopathy of the sarcoid and adenopathy or adenomegaly of the sarcoid and lymphoma. So I'll tell you how it works. These are adenopathies of the sarcoid and adenopathies of the lymphoma. What is the difference? The only difference is that the lobulations or the hostel pattern what we are commonly used to. So these hostel pattern or flower-like pattern, because you see a flower, there is a thread, you see a flower, again there is a thread. So it gives a hostel pattern-like sign, so that hence it is called as Garland sign. It appears like a garland. And in lymphoma, the nodes are almost kind of homogeneous. There is no distinction or there is no lobulations usually seen. The lobulations are there, but on the surface, not in between the two opacities. Hilum overlay sign, again an important sign, helping us to locate whether the lesion is at the hilum, anterior to the hilum or posterior to the hilum. So it is also a very straightforward sign. The hilum, we know all the contents of the hilum, right? So whenever we start seeing the inferior descending pulmonary vessel clearly, you have an opacity at the hilum, you still see the vessel clearly, that means this opacity is either anterior or posterior to the hilum. It is not a hilar opacity. It is not a hilar pathology. So this opacity may be anterior, this may be posterior. We don't know. So we confirmed it. So this was an anterior opacity. A large mass sitting here, which was anterior to the hilum. Second example, you see a opacity, you don't see the vessel separately from the opacity. What does that mean? This means this opacity or this pathology is sitting at the hilum. So whatever that pathology is, we need to confirm it. When we confirmed it on CT, it was a large node at the hilum itself. So this is the importance of hilum overlay sign. It helps us to locate the lesion, whether it is at the hilum or whether it is anterior or posterior to the hilum. Fallen lung sign, usually seen in cases of polytrauma again, high speed road traffic accidents, wherein we have lot of pneumothoraces, lot of subcutaneous emphysema, very difficult for the imaging people in this case scenario because the patient is very critical, lot of ICU kind of tubes and lines, AMBUs and all those things. So in this fallen lung sign, the lung is just falling off the hilum, because as we know, the main bronchi kind of holds the lung into position. So when the main bronchi is dissected or transected, the lung is lost its support and it is just lying by the side of the lateral chest wall or the inferior or the diaphragm. So this is a fallen lung sign, very helpful in cases of high speed road traffic accidents and usually associated with pneumomediastinum, pneumothoracis everywhere and subcutaneous emphysemas. Scimitar sign, this is associated with pulmonary drainage, like it could be a complete or a partial abnormal venous drainage of the lung. Usually, normally this structure is not seen crossing the diaphragm, but whenever this tubular opacity is seen crossing the diaphragm and going into the liver, that means there is an anomalous drain of the veins from the lung into the hepatic portal or the IVC. So that is, it gives a typical sword-like appearance, which is called as pala in the Turkish language. So this gives a scimitar sign. This is almost, we are just towards the end, two more slides. Fallen waist sign, this can depict or kind of resemble straightening of the left heart border, usually seen in cases of mitral stenosis. But this is not a case of mitral stenosis, this is a case of left lower lobe collapse. What happens in this case, when the lung, left lower lobe collapses, the heart on its vertical axis is slightly tilted, twisted. So what happens is, normally what the aortic knuckle we see very, very easily is not seen that easily. So this is a clue to pick up that there is something going wrong behind the heart. So this needs further investigations and you can confirm later. Hampton hum sign, not a very important sign. This is usually opacities based on along the diaphragm or along the lateral costal, paracostal margins. So this is just like a hump, hence it is called as Hampton hum. It was described by Ore Otis Hampton, hence it is mentioned or labeled after his name. And that is almost the end of this talk. So this slide, don't take this otherwise. This is just to say, if you understand pathophysiology of a condition, the basic thing. Actually, I had hypofied this slide from Desai, so he's not here. Otherwise, he would have given a separate lecture on this slide. So if you understand the basic pathophysiology of a process, diagnostic blunders like this don't occur. So that is just the basic thing, not to miss a basic diagnosis. Thank you very much for your patient listening.
Now I'd like the moderators to felicitate our speaker, Dr. Vare sir.